Your daily dose of wellness begins now. What I'm simply doing in this podcast is letting you know that there is risk so that it empowers you to make an informed decision. So let's look at the three types of prominent use of biopsies that are out there. Fine needle aspirate, core needle biopsy, excisional biopsies. And I want to look at this as it relates to some pretty big markers. One is survival. I mean, everything that we do, honestly, that's what it comes down to. Second is metastasis. There actually are studies looking at this. And so what we want to do, as we always do on this Prescribed by Dr. Nathan Goodyear podcast, is look at the evidence and dive through that process and see what the evidence says. Not get ahead of the evidence, but simply follow the evidence. So there was a hospital registry-based cohort study in 2020 entitled The Association Between Methods of Biopsy and Survival Following Breast Cancer. Pretty straightforward. It's already said we were going to look at that. And they were trying to determine what was the impact on survival based on the type of biopsy. Now, this included 3,416 non-metastatic breast cancer patients, and they followed them from 1993 to 2011. So they followed them for quite some time. 990 patients were diagnosed via the core needle biopsy, 1,364 by the fine needle aspirate form, and another 1,062 by excisional biopsy. So looked at fine needle aspirate, core biopsy, and excisional biopsy. And then they actually modified this with radiotherapy, so radiation. So a group received radiation after biopsy, a group did not receive radiation. And what they found is that the radiotherapy modified the prognostic impact of the biopsy method. In the absence of radiation, core needle biopsy was associated with a higher risk of mortality than the fine needle aspirate. So the take home here is that breast cancer patients diagnosed through needle biopsies had a significantly lower overall and disease-free survival. Kind of amazing. So you can actually look at studies, looking at humans, looking at breast cancer, looking at the three types of biopsy and go, which biopsy type provides me as a patient with the best overall survival and best overall disease-specific survival. So let's tease this data out just a little bit, looking at the fine needle aspirate cytology, the core needle biopsy, and the excisional biopsy, and look at this 5-year overall survival. And it's really interesting when we look at the biopsies plus radiation of those three groups. The median in fine needle aspirate was 5-year survival rate was 81.2%. Core needle biopsy was 84.8%, and excisional biopsy was 89.4%. So again, what we see there is that the biopsy type with radiation, the lowest overall 5-year survival rate was in the fine needle aspirate cytology. The best was with excisional biopsy. That's important information to know. But what about biopsy without radiation? Because there's not a lot of patients receiving biopsies and then receiving radiation to those biopsy sites. Likewise, there's not a lot of people getting biopsies and then getting retraction of the biopsy site, as I talked about with the local seeding and the left behind cells. So in the biopsy without radiation, the 5-year survival rate overall in the fine needle aspirate cytology group was 82.7%. The core needle biopsy was 82.7%, and the excisional biopsy was 90.3%. So you can see even without the radiation, the lowest survival rate here, 5 years, was in the fine needle aspirate, but that really was the average was equal to the core needle biopsy. Again, the best there was the excisional biopsy. Another article, so that's looking at overall survival and progression-free survival. So, bring that to your doctor when you talk about the type of biopsy. They probably won't be aware of it, but check out the notes, the show notes, because the references will be there and you can take that with them. There was a Swedish study, interesting study, and it was published in when was that published? Core needle biopsy, 2017. Core needle biopsy of breast cancer is associated with a higher rate of distant metastasis 5 to 15 years after diagnosis than a fine needle biopsy. Now, in the 1970s, the only diagnostic biopsy method in Sweden was the fine needle aspirate biopsy. Then in 1989, they switched over to the core needle biopsy. That became the standard, and this carried on into the 1990s. And so they compared the clinical outcomes of patients diagnosed using that fine needle biopsy from 1971 to 1976. And then they also then compared that to the core needle biopsy from 1991 to 1995. So they compared these two groups basically at the height of their use to see what was there a difference in the 5 to 15 year metastatic risk in distant sites. And what they found was this: fine needle aspirate and core needle biopsy cohorts significantly higher rates of late appearing, that's 5 to 15 years after diagnosis. That's a long time, folks. Again, 5 years, no evidence of disease would be considered a cure. Back to the quote. Distant metastasis were observed among the patients who were diagnosed on core needle biopsy compared with those who were diagnosed on fine needle aspirate biopsies. So what they're saying here is that the core needle biopsy is associated with a higher rate of distant metastasis. So if we look at these actually three data points, overall survival, progression-free survival, the fine needle aspirate seems to have less survival there. When we look at the 5 to 15 year metastatic risk distantly, which obviously 90% of morbidity and mortality associated when cancer spreads, core needle biopsy has the higher rate of distant metastasis. Now, when we look at the fine needle aspirate, remember, I've had this quote earlier. It was a study published in Oncology in 2000. Undertaking the fine needle aspirate does increase the hematogenous, the blood circulating tumor cells from breast cancer. So this is something that really, the risk is extrapolated to each one. Fine needle aspirate, core needle biopsy, excisional biopsy. But you have to look at the core needle biopsy and fine needle aspirate biopsy because those are the most commonly employed today. But each one of them carries real risk, not rare risk. Again, we're not talking about diamonds here because diamonds, though they're rare to be formed, they are everywhere. What we're talking about is a synthetic risk that we create with the biopsy. And again, back to that quote, given that our results contradict with findings of previous clinical studies assessing the prognostic impact of method of biopsy in women with breast cancer, further studies are warranted. It's so interesting when you read studies and there's profound findings in the studies when the study's properly designed, powered, and the conclusion matches. And if it challenges the status quo, if it challenges the standard of care, there's this, well, we need more studies. Well, when is enough enough? So here they're actually kind of skirting the conclusion of the data by saying, well, this is interesting, but we need more data. Now, we talked about seeding, we talked about local seeding, tracks, we talked about distant, but let's get into some very quickly deep underlying issues of what might be being disrupted by these biopsy. Well, there is this process called tumor immunoediting, where the immune system can actually keep tumors in check. Immunosurveillance, so the immune system monitoring cancer, was actually first suggested by Paul Ehrlich in 1909, and you'll hear his name be mentioned by me a lot as it relates to chemotherapy, but because he brought forth the magic bullet theory and the use of chemicals to treat disease, valsartan, in the treatment of neurosyphilis. But actually, Lewis Thomas in 1959 and Sir Frank Mark Farlane Burnett in 1970 were the first really to look at immunosurveillance theory for tumors, and they actually proposed that. So what we have here is that we have a tumor that the immune system can keep in check. There's three processes here in immunoediting: immune elimination, equilibrium, and escape. So in elimination, obviously the immune system is eliminating the tumor. In escape, the tumor is escaping the immune system. But in equilibrium, what's happening is that the immune system is basically in a balancing act with the tumor, and tumor growth is being controlled. It's in equilibrium. So when you come in with a biopsy, could be a fine needle aspirate, could be a core needle biopsy, could be an excisional biopsy where maybe you don't get all of it, but particularly talking about the core needle biopsy and the fine needle aspirate cytology biopsy, you disrupt this equilibrium that could exist, and then allow it to move into the escape phase, or then have it in the elimination phase where maybe actually the immune system is doing the job, but you actually move it and shift it through the equilibrium to the escape phase. So there's that old saying, sometimes just because you can do something doesn't mean you should do something. But when we rush to biopsy, we could cause a pivot, a shift in this immunoediting phase process, which we know exists, this immunosurveillance process that then could allow this process to pivot where the cancer, the tumor, is actually evading the immune system. And this is where you get the reduction in overall survival, the reduction in disease-free progression, and the increase in 5 to 15-year metastatic risk associated with core needle biopsy there over the fine needle aspirate. So, granted, I do think we need more studies, but we understand that there is real risk. And so if your oncologist tells you, if your surgeon tells you there's no risk, just show them the studies. So again, check out the show notes. But looking at surgery-induced local recurrence, here not talking about biopsy, but actually just surgery. So this applies more to excisional biopsy. Really interesting, looking at local cancer recurrence, the realities, challenges, and opportunities for new therapies. Breast local recurrence, 5 to 25%. Non-small cell lung cancer, 5 to 40%. Pleural cancer, 35 to 65%. Peritoneal cancer, 40%. Retroperitoneal sarcoma, 25 to 69%. Rectal, 4 to 8%. So I think there's a cavalier attitude and approach that a lot of oncologists and surgical oncologists will take to biopsies and even surgical resection. And what you can see is, no, there's very real risk. And I often say, for example, if you look at a hysterectomy, the risk of death on the table with a hysterectomy, it's less than 1%. But if you're that 1%, that's 100% to you. Reminds me of a particular case when I was back in Louisiana. There at the hospital I was working at, there was another colleague who was doing a hysterectomy. It was somewhere around December 15th, can't remember the exact day. But it was a mid-30 patient, had a couple young kids, married, and they were doing a routine abdominal hysterectomy for, abnormal bleeding that wasn't controlled. And the patient had a massive heart attack on the table and died. So, risk for death at the time of a hysterectomy is very rare, but it was very real and very 100% for that patient. And that's where you kind of get that saying, N of one, meaning the risk can only be extrapolated to that one individual. So when you talk about, 75%, what does that even mean? 75% risk of success, of remission, it really comes down to how does that apply to you? We can look at those numbers, we can look at that data, we can look at that risk, and then we have to apply it to the individual. What I'm simply doing in this podcast is letting you know that there is risk so that it empowers you to make an informed decision. So what we need is innovation. I'm wrapping this up. We need innovation in biopsies. It'd be nice to be able to do surgical resection of the biopsy tract, but as that one study pointed out, that's not something that's going to be routinely done, offered, and it's just not going to be reliably done. So that's probably not going to be the solution. Radiation, no, that's not a good solution either. Radiation is the paradox within a paradox within a paradox within a paradox within a paradox, because radiation causes cancer, radiation is used to treat cancer, radiation causes local recurrence, radiation causes distant metastasis, and radiation causes secondary cancers. So we don't want to add that in. So the tract's out, the radiation's out. But what about if we take a biopsy and then with the needle still in place, we actually then ablate the tumor and then we inject intratumoral immunotherapy? This is something that we've actually done down at the Williams Cancer Institute, where we've needed an additional biopsy. Now, there's risk with the biopsy, as I've already highlighted, but what we've done is through one stick, one needle, we took the biopsy, we ablated, and we then injected intratumoral immunotherapy to activate the immune system against that local tumor. So you're diagnosing and you're treating at the same time. So we've taken that approach, and I think that's something that really should be expanded upon to really optimize outcome for patients and really eliminate risk. But it would be nice if we could just simply move away from biopsies altogether and actually move towards the liquid biopsies that you may or may not have heard of. And this is further innovation that you're continuing to see to advance. These are the liquid biopsies like Guardant 360, Boston Gene, and many others. And these are looking at, circulating tumor cells and fragments of genetic material from the cancer cells that's circulating in the blood. And then at that point, using this to diagnose. And so what's interesting here is this is typically used alongside biopsies, but maybe this will replace biopsies. Now, I don't think we're there yet. But here's the exciting hope. We're moving that direction. And so we have also the ability, though, to take that technique and apply that, because where that is applied right now, the Guardant 360 and Boston Gene, it's applied in the genomics and transcriptomics as it relates to treatment. But if we applied that tissue-free circulating tumor DNA to breast, circulating tumor cells, and lung cancers, there's actually a test called Reveal, and it's with the Guardant company, Guardant Health, and it's actually being used there as a screening diagnostic tool. So we're moving that direction where hopefully one day we can limit or move away from biopsies, just like hopefully we can limit and move away from surgical resection, limit and move away from chemotherapy, limit and move away from radiation, and move towards precision, but yet low risk to the individual, and allowing us to develop a individualized, precise treatment based on integrative oncology. So I hope that this podcast talking about just the real risk, the evidence behind the different types of biopsies out there. A little long-winded, I know, but evidence that's out there. And I think it's a very important discussion for us to have had, because so many patients report to me that when they go to their doctor and they talk about their concerns about the biopsy, they're really shut down by their doctor in this debate. And I just don't think that's appropriate. So this empowers you. And that's really the goal of what I'm doing today by working with the Williams Cancer Institute, is to empower patients, empower doctors to provide better care for patients, but to empower patients to really take control of their health care, of their cancer care, provide innovation, talking about the biopsy, the ablation, and then the intratumoral immunotherapy. That's innovation. And then elevate the practice of medicine through empowering other doctors. It's great to help 15 patients heal, but if we can help 15 doctors heal 15 patients, now it becomes exponential. Thanks for joining me on this Prescribed by Dr. Nathan Goodyear podcast as we walked through biopsies, cancer, and risk. Share this with those that would benefit from this information, and we will see you on the next Prescribed by Dr. Nathan Goodyear. Thanks for joining us on this episode of the Prescribed podcast. All references supporting this episode can be found on the prescribed.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.